Hope I'm audible and we'll start this meeting. Uh, we are going to discuss today about topic that is adult onset still disease. And if you really see, uh, this is kind of, we all face it during MD medicine. And the first case is always fascinating. And after solving the first case, we overdiagnose the AOSD and we miss a lot of common things also. So that keeps happening, but still in practice also, whenever we are called for PUO case, pyrexia of unknown origin case, your vision should be broader that we are not narrowed down to one specialty, like let it be infectious disease or malignancy or rheumatology. Do not go too much with a narrow mind when you say that, okay, this patient has been already seen by 2 3 specialists and it is now unlikely those cases are there, right? Sometimes we are called for oncovasculitis and we make diagnosis of infective endocarditis, and sometimes we make diagnosis of oncovasculitis and it turns out to be infective endocarditis. Both the way it happens and things goes bad for patient at the end of day. So we will try to overcome from that by knowing the disease well, and then when to suspect and how to manage. We'll keep this question and answer at the end. Whomsoever has doubt can ask, and we'll proceed. Fine. So if we see this the discussion outline, I will initially for 2 to 3 slides just for setting a exit stage for AOSD. I'll discuss about PUO. Already there is a very proper class on that already available. Then we will introduce the AOSD, that is adult onset still disease. We will discuss its clinical feature, pathophysiology. I'm pretty sure no one is interested in pathophysiology, but then you will realize if you know this, you know almost everything. Then the differential diagnosis and what do we do on day one, how to manage all these cases when we suspect these cases, right? So this is the total outline of our presentation. So if we tell PUO, this was the previous definition: fever on 2 occasions at least for more than 3 weeks with an uncertain diagnosis despite 1 week of inpatient evaluation. So that was the previous definition. It required admission for 1 week. Now we know that if patient is not sick all the time, we do not admit and we try to find cause. And to be honest, if patient is not sick, patient has fever, we give augmentin, azithromycin and send them back, right? So that's the second scenario which makes PUO most of the time, not the first, that we try to find cause all the time. When patient is stable, we think there is no much major disease right now going on. The worst cases in your clinical practice are, they say, sir, yesterday I had 103 fever, and when patient is in your OPD, he is perfectly stable, no fever, and will be thinking, should we admit him? Is he really telling truth or is he lying? Right? So those kind of scenario keeps happening. But believe me one thing, that when patient comes to you, definitely he has some problem which requires solution. You see our behavior, the reluctance to visit a doctor. We do not want to spend money. We do not want to get those hospitals in as a patient. So all the time, if someone is coming to you, definitely there is a genuine problem which requires to be solved. And someone will be telling that, no, that varies from practice to practice area and everything. I agree with that. But if patient has come to you and the another doctor is making diagnosis, we won't be happy, right? So for your sake, you have to solve the case for sure. So now this is the revised definition. Again, everything is there in your Harrison. So again, they kept that fever on 2 occasions for at least 3 weeks, but they removed the inpatient evaluation. But they added there should not be any immunocompromised state. Means you cannot tell an HIV/AIDS patient having fever as a PUO case. You have to find cause, but there will be different workup totally. The diagnosis that remains uncertain after thorough history taking, I will say history taking twice, thrice, or 4 times, physical examination, specifically for lymph node, hepatosplenomegaly, some rash or eschar, and following obligatory investigation, right? So if our basics are done correctly and patient has fever, which is for more than 3 weeks, and patient is not on immunocompromise, that is PUO by definition. Now, if you are really doing good in your practice, you have enough differential for PUO, mostly you will not get cases of PO. Many of the time, like when we'll be in rounds, A 1 week fever which is not solved will be labeled PO. Now, let me tell you one thing that does not irritate me at all, because we do not follow definition when we practice, right? It is not required. If my doctor says that, okay, 1 week he has been thorough in his workup, nothing is getting, then it is PO. Then why this 3 week? This 3 week, for one reason, is MCQ. Fine, take it. The second important reason is, suppose if someone wants to do a thesis on PO, okay, so he has to have a definite set of criteria on which he will do thesis. For that, this kind of definition do help. Okay, they come in Viva, they come in MCQ, but believe me, when you come to clinical practice, you cannot follow it strictly. If patient fever is for 2 weeks unsolved, will you tell that let it be 1 week more? Then we will work like PUO. Till then, take paracetamol and go home. We don't do that, right? So this definition or things are little flexible in clinical practice, but they are not flexible for your MCQ. So just treat it like that. How do we proceed with a case of PU? So search for PDC, that is potentially diagnostic clue. Localizing signs, suppose you found some oral ulcer, you found lymphadenopathy, you found hepatosplenomegaly, you find bony tenderness. Those are localizing sign. You find a tender abscess somewhere, gluteal abscess, right? So sometimes you won't be able to find exactly what it is, but when you examine completely, you may find one clue. The symptoms and the abnormality potentially pointing towards a diagnosis. So we have to actually look actively for those things. Complete and repeated history taking and physical examination. It requires obligatory investigation, chest X-ray, ultrasound, blood culture maximum 3, urine culture 1 only. This is your PUO basic workup. This much we can do. I order echo for PUO. I always want to rule out infective endocarditis because a specialty I practice mostly requires steroids. I cannot give steroid to a patient who is having active infective endocarditis. I cannot do that mistake, right? So it is very important that we do enough appropriate workup before labeling something with rheumatological disorder or malignancy, because something like infective endocarditis can mimic a lot. Something like disseminate TB can mimic a lot. So infectious are always a priority when you deal with PUO, right? Because infection is a rapid progress which can actually screw patient faster than your rheumatological disorder or your neoplastic disorder. This is not rule, but this is a general tempo of the disease what we try to follow, right? So this is how we proceed. And this is a very important line to remember. In patient with recurrent fever, where the repeated episode of fever interspaced with the fever-free interval for at least 2 weeks, chance of attaining an etiological diagnosis is less than 50%. Now, see, this is the line from Harrison, what has been written here. It is less than 50% in which setup we have not written, right? If we have an adequate workup, then the chances will go even little less, right? If we do not have adequate workup, then it will go even 80-90% also. Sometime at the end of the investigation, like PET scan solves the case. But when to order PET scan is up to you, right? So PET scan should not so generalized lymphadenopathy in the cervical lymph node should not look very bright on PET scan, right? Because we have missed it then. It's not something we do, then we see uptake and do biopsy. We examine if there is a palpable proper lymph node, you do a biopsy and you try to find what it is exactly. Then after that, you want to determine the extent of disease. For that, you are ordering an additional investigation. That is a valid practice. It's not something for all PO. We are going to order PET scan where uptake is increased. We are going to biopsy that part. No, it does not work like that. You have to go for a simple investigation first. I will say cost effective investigation, which are logical first, then the PET scan. You respect the radiation there, right? So talk in this direction or think in this direction when you get the PUO infection all the time, bacterial, fungal, parasitic, viral, rheumatological disorders, vasculitis, granulomatous disease like sarcoidosis, autoinflammatory syndrome. And now let me tell you what we are going to discuss today. Adult onset Still's disease is a part of autoinflammatory syndrome. Autoinflammatory syndrome, right? It behaves like that. It is little different than your routine autoimmune disease. These are two different things, autoinflammatory and autoimmune, right? You have a separate chapter on autoinflammatory syndrome under your rheumatology. Think of malignancy, specifically hematological malignancy, some solid tumor, specifically hepatocellular carcinoma, renal cell carcinoma can have fever as one of the major manifestation, or sometimes benign tumor also can cause fever. Again, the same rule, recurrent fever lasting more than 2 years is very unlikely to be infection or malignancy, right? 2 years, which infection is going to run? Very unlikely. 2 years, which malignancy is going to run? Very unlikely. I'm not telling impossible, I'm telling unlikely, right? Sometimes we have to think of thermoregulatory disorder also, like central disorder of brain tumor, cerebrovascular accident, encephalitis, or hypothalamic dysfunction, where the temperature is regulated. If that part is affected, patient can have high temperature, what we call it fever, right? Now the fever is little different and hyperthermia is little different. Both are discussed well. You have to know those parts. The peripheral causes of thermoregulatory disorder includes anhidrotic ectodermal dysplasia, exercise-induced hyperthermia, hyperthyroidism, and pheochromocytoma, right? So sometimes I think many people might have seen the case which was PO and hyperthyroidism solved the case, right? But sometimes what happens is the case was PO and TSH somehow tells it is hyperthyroidism, but really there is something else also inside. So when you get a one diagnosis, don't get so convinced. If your natural history is not fitting, keep your eye open. Okay, the Occam's razor say patient will mostly have one disease, but it is mostly not all the time. Sometimes you can have two diseases also. So be with that. You treat that this is what you have caught first. But if you think there is no great response, start respecting more things that we are missing something, right? So that is very important when we consider. Okay, now we will come to the main part, that is adult onset still disease. And I'm going to keep it more and more clinical. I will involve some basic concept also of a very minor things of cytokines and all, but that is not going to be in great detail. What I really want you to focus today is we start suspecting this and we start dealing with this disease because it does exist. Whatever I will say, in every 3 months, 1 or 2 diagnoses of AOSD I make when we are called for PUO. Okay, so it is not uncommon. It is quite common. The worst thing happen is ordering too many investigation and getting so many false positive, which keeps us confused, right? So we have to be very straightforward and clear what we are dealing with. So when to suspect this adult onset still disease? See, right now I'm assuming that we all here are treating adult patients as a physician. So that's why it's an adult onset Still's disease. If that happens in pediatric, it's called Still's disease. That's all. So Still's disease was initially described by Stills, and after that, the similar presentation was found in adults also. So we labeled it adult onset Still's disease. In pediatric Still's disease, the other name is systemic onset JIA, SJIA. Okay, so this is kind of a description. Okay, it's a kind of a continuation of one disease which exists in pediatric but also can present in adult. Why it is so much important that I have to know about pediatric also? I will come to that. Not for MCQ, for real practice you should know it. Okay, I'm not telling you to manage pediatric patient, but I'm asking you to take that pediatric history properly. Do you take history of acute rheumatic fever for them or every RHD case? Yes, we do. It helps us. The similar way it is going to help us, right? So keep it in mind. I will come to that part. So what are the cardinal manifestation of the AOSD? It's a skin rash, fever more than 39 degrees Celsius, leukocytosis with neutrophil predominance, and arthritis or arthralgia. Okay, so these are the major manifestation of that. What can be the additional other manifestation? Odynophagia, that is sore throat. Then myalgia, myositis, they can have lymphadenopathy, they can have splenomegaly, they can have pericarditis, myocarditis, pleuritis, or lung disease. Very important to note, we have not written endocarditis here. It's a peri or myo, but not the endo. They can have hepatitis, they can have high ESR and high CRP with very high ferritin. And when ferritin goes high, the subset of glycosylated ferritin goes down. And they can have coagulation disorder in the form of the hemorrhagic manifestation also. Now, let me give you a scenario that you are admitting a patient who is a 32-year-old male who has fever for last 7 to 10 days. And when you evaluate this patient, you find that, okay, patient has total count of 16,000 with neutrophil more than 80%. When you see the other reports, patient has transaminitis and patient has elevated CRP and ESR. When you examine further, you find some splenomegaly and some lymphadenopathy also. And patient tells that before all these things started, doctor, I had some throat pain also. So everything looks okay. Patient had throat pain. After that, fever with high CRP, ESR, with leukocytosis and everything. Am I dealing with acute rheumatic fever? Or am I dealing with many other diseases which can come into this picture? Right? So this can be a real confusing thing. And then the things goes bad. We order echo, and echo does not show endocarditis. Echo does not show anything else, but there will be a comment. There is a thin ream of pericardial effusion. Again, we are confused what we are dealing with, right? Then someone smart comes and tells, okay, you have fever, you have lymphadenopathy, you have splenomegaly, you have high CRP, you have transaminitis, you have pericarditis. We are probably dealing with lupus. Let's send ALA. And sometime by mistake it comes positive 1+, right? We all are like, okay, case is solved, it is lupus. It was not lupus. It was not lupus, right? So you have to actually keep it very proper. The initial description, lupus does not start in 10 days, come on, right? It does not start with so fast. So you always have to respect the tempo of disease. It can start when you find a case report, someone will put a paper on my face. Let's see, there is a case report of 7 days lupus. Anyone can publish case report, man. See the journal there, right? You have to be really good while reading articles, that what you are reading, from whom you are reading. We cannot accept facts which are written on publication, not all the time. It can be wrong, right? You have to see patient, then you have to correlate that, okay, whatever patient of lupus I have seen till now, does it match the history? No, it does not match. Whatever patient of acute rheumatic fever I have seen like this, does it match? Yeah, it matches little, but I have never seen transaminitis with acute rheumatic fever. That's an odd point, right? I do not see pericarditis without valvular disease in acute rheumatic fever. That's an odd point. Yeah, those are the odd points which is actually shouting loudly that we are missing something, right? So that is a point we have to keep in consideration. Sometime AOSD can go very bad. They can have cardiac tamponade, myocarditis, ARDS, pulmonary artery hypertension, fulminant hepatitis, macrophage activation syndrome, where your ESR will form and fall and CRP will stay high, and they can have thrombotic microangiopathy or DIC also. So this is actual spectrum. Now tell me how many patient you see like this. You see lot of patient like this. Most of the time you get the solution. Sometimes we do not get the solution. And there we have to suspect AOSD. A very important clue will be ferritin. That's my magic all the time. When I'm called for a patient, when he has similar kind of manifestation, see, the part is, whenever we are called for patient, it is not something we crack the disease very fast. It is the workup which is done, that for 5-7 days patient was in hospital, patient was throwing high fever, received higher antibiotic, workup was done properly, almost everything was fine, we were not finding any clue, means the major disease were ruled out. Okay, then I will look for my checklist. Echo is there, sonography is there, blood culture is there, the examination is done properly, everything is done properly, and then you have a patient with fever, some kind of arthritis, neutrophilic leukocytosis, and some splenomegaly or lymphadenopathy with high ESR CRP, I will order ferritin. And that will come sky high, and our confidence in diagnosing AOSD will increase. If someone calls me next day that sir, ferritin is 280, no, it is not AOSD. It is not AOSD, right? Someone calls ferritin has come more than 2000. Oh, it is very likely we are dealing with AOSD, right? So see, this is something we are discussing, a case which is unsolved and we are waiting for the report next day. It's fine, we have to wait. So what we are going to do till next day? We are going to wait and we are going to give symptomatic treatment. How to do that symptomatic treatment, I'll come to that, because that matters a lot to your patient, right? So this is where you suspect AOSD and what is the spectrum. Before we go ahead, I really want to go in this patterns of AOSD, right? The complex of AOSD is a skin rash, fever, and plus minus arthritis or arthralgia. These are their major manifestation. They can have sore throat, or see, do not confuse odynophagia. It is a textbook word. The patient will tell sore throat and you will also write sore throat there. They can have myalgia, myositis. You can find this lymphadenopathy, splenomegaly, and these are the mostly report you will find that is something wrong there. And sometimes patient can be too sick. There you have to suspect you might be dealing with AOST if your infectious etiologies are not looking that impressive, or if your patient is not responding to antibiotic very properly. You have confidently ruled out any hidden abscess or infective endocarditis. Start thinking AOST, right? So this is what we keep thinking. Now, see, this is something I will tell you a few of the case what we have seen already. That a case who was a 13-year-old girl who came with presentation of fever, arthritis, rash. She had high ESR, high CRP, and everything. And then it was diagnosed, echo was normal, and it was diagnosed it can be possibility of acute rheumatic fever because ASO titer were high, and patient responded well to naproxen, that is your NSAIDs. Now AOSD has one characteristic, that it has good response to NSAIDs. There are few diseases in the world which responds beautifully to NSAIDs. One is your acute rheumatic fever. The other is what we are dealing here is adult ancestral disease. Third is your spondyloarthritis. If these three diseases are not responding to NSAIDs at all, they do not exist there in majority of the time. Okay. When I give this NSAIDs to my spondyloarthritis patient, he will tell me next day, sir, there is a 30-50% improvement. When you give this NSAIDs to your acute rheumatic fever patient, you will be very happy. Nothing is there. When you give this NSAIDs to your adult ancestral disease patient, he will tell, sir, for the first time, I did not have fever yesterday. So it is going to do its magic. But again, it leads to confusion because what it is, and then we decide the treatment. So before we go there, let me discuss little about fever here. That fever in adult ancestral disease is daily and intermittent, and it is high grade fever. When patient is having fever, he is the sickest person in your ward. When the fever is gone, he is playing on mobile or he is roaming around, nothing is there. That's a typical character of AOSD fever. The constellation of the symptom, the fever, joint pain, skin rash are together. For that duration, patient is sick. If you really examine, patient will have some rash, but when the fever goes down, rash may disappear. Now, that's why I'm not discussing rash too much, because we do not see it commonly in the dark skin individual what we have. Okay, I'm not giving anything on color right now, but we do not see rash very commonly on our Indian patient when we see the AOSD. So skin rash does not give me the diagnosis very fast. Okay, fever pattern and specifically this description that, yeah, when patient had fever, he was sick, he was on the bed, he was not able to do anything. The pulse rate was 130, and I thought that I will shift this patient to ICU. He is that sick. But the moment that fever is gone in 3-4 hours, sister gave paracetamol, it did not work. Then after 3-4 hours of fever, it automatically came down, and the fellow became so normal that he was completely fine. And that can happen when you took the morning round, patient was quite stable. You wrote everything is fine. When your consultant comes in round, he is having 103 fever. And we are like, what the hell, right? Actually, he is giving you diagnosis, or he is giving diagnosis to your consultant. We both should trust each other and crack the case, right? That's how it happens. So the fever is very important to describe and see that what exactly happens. That's what I was correlating your that OPD patient that who came to your OPD tells, yesterday I was quite sick and today, doctor, I'm fine, but I'm really telling I was sick and I'm scared. That may be the AOSD case what you are dealing with, right? So it's a very important history to keep in consideration. So now this is one pattern, that patient gets disease for one time in life, and after that he never gets disease. Everything is fine. Nothing happens. So this still stays kind of a enigma that, okay, what happened? But in India, what will happen? This was the case of AOSD just because ASO titer came high, but the other evidences were not that great, and patient ESR CRP were elevated. Patient responded beautifully to NSAIDs. It was labeled as ARF without cardiac involvement. I agree with that. I completely agree with that. And then we start antibiotic prophylaxis till the age of 21. right? So does that patient deserve that from 12 to age 21? Antibiotic either daily or every 3 weeks as per Indian schedule? I think no. So we have to try a little hard to prove it that what exactly we are dealing with. And I'm pretty sure that we cannot solve it in day one by discussing this, right? But if you are practicing, you have to start finding patterns that is it really the pattern of the joint pain of migratory polyarthritis of acute rheumatic fever, or it is something the oligoarthritis or the symmetrical polyarthritis of adult onset still disease or the Still's disease. If the stress disease is there, ferritin will be too high, there will be transaminitis. In whatever your patient of so-called ARF, if you had transaminitis or by mistake, if you have sent ferritin, it has come high, it is unlikely to be ARF. He does not require lifelong therapy or the like antibiotic prophylaxis till the age what the schedule says, right? So that makes difference. And I really want to do that when we deal with our patient, that give the best, right? So that's the first pattern. Now it's fine that, okay, we discuss so much and nothing turns out and we have given antibiotic, it has not done any harm. It's fine. 21 age is over, he is free of antibiotic, life is good and he does not develop them anything. He keeps telling everyone in the world that he had ARF, but after that the cardiac damage did not happen. He is luckily living totally normal, perfect life. We both are happy, right? Patient is happy, doctor is happy. Still diagnosis was not clear. So God is great. The things are going good. Now see the second case. So this boy who came at age of 8 to 9 years, again admitted as PUO, no one could solve the case, was labeled acute rheumatic fever or unsolved PUO, was given all kind of treatment. Suddenly someday after 3 to 4 months, the fever goes down and life is good. He joins school back again and he's doing absolutely fine. Now at age of 28, he suddenly comes that, okay, I have fever, I have rash, and when you order investigation, you get leukocytosis with neutrophilic predominance, high ESR, high CRP, and then the confusion starts. At this point, you ask patient any other illness in the past. So he tells, yes, when I was at the age of 8 years, I had similar kind of fever, and that time it was told to me this is acute rheumatic fever. Doctor, till age of 21, I was receiving this prophylaxis also regularly without missing anything. But I think my illness has come back. You send ASO titer, it comes sky high again. And you'll be, yeah, this is second episode of acute rheumatic fever. Okay, we are getting fooled here, man. We are getting fooled here, right? So we have to actually consider this part very particularly, that how a patient can have this kind of acute rheumatic fever again and again. They can have, okay, I don't deny that, but usually no, right? Our immunity is good. So how they can have that episode like that? Have you looked at liver function? Have you looked at ferritin? Please answer that. Now does your echo says at least there is a trivial MR or TR or AR, right? Nothing is there, damn echo is fine. It still tells there is a thin rim of pericardial effusion. And you're again, okay, pericarditis can happen in ARF, can happen. I agree with that. Fine. But this does not happen like this all the time. So this is the second episode, second chance. Again, here we worked up like PUO, we gave all the things possible. We were sure there is no infection. So someone told, let's give steroid, and patient was magically responding. And then you stopped everything, patient was fine, and things are fine. And after that, again, he develops. This is the polycyclic pattern. The third pattern is something he develops, but he never goes in remission. He still have persistent pain. See, now this is easy to catch. That patient is having persistent problem, and acute rheumatic fever cannot go like this, right? So it is easy to catch. There is no confusion in this. No infection can go like this. So it is easy to catch. These are challenging cases, right? And sometime at this point, I will be explaining my patient, okay, you got AOST, will require a good time treatment, maybe 6 months and all. After 2 months, patient tell, no, doctor, I stopped all your treatment and nothing happened to me. And sometimes nothing happens to him. So he will keep blaming that my doctor was telling I had a disease called AOSD and nothing happened to me. We are aware that he's telling truth, but sometimes they do not trust us because we told you have a major disease which requires proper care. Now, why I keep telling my patient that it requires proper care? Because the arthritis of AOST sometimes can be very severe, and there can be the wrist arthrodesis kind of fixation. There will be erosion and all. So patient won't be able to move wrist in the later stage. So I need to take care of my patient. They can have sometimes a severe hip arthritis, and there will be requirement of replacement at the later stage. So I need to save that hip. So all the time, whenever we deal with these cases, we have to be well aware we are dealing with this. I will not go in more of the arthritis part. Let's keep it focused on fever, because that's a PUO case we are going to solve. Now, these are your diagnostic lab clues. Before I come to this, I really want you to focus it here, that these are your actual clues: transaminitis, high ESR and CRP, leukocytosis with neutrophil predominance, and thrombocytosis. These are your major clues you will make a diagnosis. See, now let me tell you very clearly. The first day is always a routine investigation in most of the case. No ANA on day one has saved them any life till now. So ordering ANA on day one, because this kind of constellation is there, it is useless. Because if it comes 1+, you will stop thinking everything. You'll be thinking, okay, this is lupus, right? Start steroid, start HCQ. Don't do that. Don't do that. Because this patient is going to respond to that. And once you label it lupus, it's for lifetime lupus, right? Then you will order ANA profile, and which will come negative, or sometimes that also comes +1. That can confuse you. So whatever happens in clinic, the laboratory should not guide you. You should be guiding the laboratory investigation depending on your history and examination. See, that order is not going to change. A, B, C. It can never be C, B, A. Okay. So that is a very simple thing. History, physical examination, probable differential diagnosis, routine investigation, and then you go little specific investigation. That is never going to change, right? So now this is the part we are going to, we know already this can be the pattern of AOSD. CRP is a very good test that, okay, it will be mostly high, but it does not have specificity, right? It can be high in osteomyelitis, it can be high in infective endocarditis, it can be high in pneumonia, there can be so many things, but it will be mostly high in AOSD. AOSD with normal CRP, we do not make diagnosis so comfortably. Ferritin will be high. Again, it's a sensitive investigation. Normal ferritin in AOSD, I'm not convinced at all, even though everything else is fitting. I want to find something more, right? Ferritin more than 5 times, yeah, it has again a good sensitivity and good specificity also, that okay, in 40% of the patient, it will be more than 1,000. So when it comes, the specificity increases, but it tells everyone will not have ferritin more than 5 times, more than 1,000. It will not be there for everyone. So 700, 800, 600, okay, it deserve a respect. But more than 1,000, it requires a very good evaluation for AOSD. We do not have glycosylated ferritin in our laboratory, in our Indian setup, in most of the places. So we do not discuss, but in MCQ, this comes. The glycosylated ferritin will go up in AOSD, will go down in AOSD, it will go down. Because see, we will be trained so much that, okay, ferritin goes up, let it be glycosylated, who cares, right? No, it does not happen like that. It goes down. It is repeat MCQ of your PGI. So it goes down, right? And then you make a ratio of glycosylated ferritin and ferritin, it will definitely increase your sensitivity and specificity. Now, see, this is all statistic. We just follow a simple rule that they should have high CRP, they should have high ferritin. That's all. With normal CRP, normal ferritin, we are not going to suspect AOSD very much. I'm not going to suspect at all. I'll be honest. Now, one more catch: procalcitonin sometime can be high in AOSD. So we were like, yeah, patient has fever, patient has leukocytosis, patient has neutrophil predominant leukocytosis, high CRP, high ESR, procal is positive, lung has some shadow, pericardial effusion is there. Dude, I'm dealing with something, infection, bacterial or fungal infection, which is probably disseminated. Okay, we all get screwed here. So do not rely on your labs. If you're relying on your labs, know them very properly, where it can be false positive, where it can be false negative, in which patient it should be sent, in which patient it should not be sent. Then only practice can go well, right? Now, this I'm not going much at all, but let me tell you one MCQ. IL-18 is one molecule which has good sensitivity and specificity. And specifically, if value is like this, you see the sensitivity and specificity. So there are now many of the kits which are going to come to measure IL-18 level to see that whether patient is having this AOSD or not. But believe me, there are so many diseases in the world which can have high IL-18. So if you do not have your clinical pretest probability by your history and physical examination, IL-18 is also an useless investigation, right? So we have to be very clear on this, what we are dealing with. This, whatever slides are rotating, it's actually your short note of AOSD, right? You suspect when there is a PUO. These are the clinical manifestation. These are the clinical course. These are the lab clues. These are the advanced lab clues. But why all this thing happen? Now see, I will tell a very simple thing. We cannot answer why in medicine. We can just answer how in medicine. Why things are happening, it is beyond a human capacity to think even. How? Yes, we can solve something. It's more of a philosophical thing. Give it a good try. Why and how? We know how in medicine. We do not know why in medicine. Right? Now, see, you saw all this thing. There are three kind of course. Did you ask a question that why these are three kind of course of a similar one disease? This is very important thing to have. Why these are the courses like this? Okay. Now let me go in little detail. Don't get bored here. Don't try to remember them everything. I'll give a very simplistic view of this diagram and then we will see. And I will say being rheumatologist, that's I think one advantage. This does not look scary to me at all. Okay. We understand this. So now see you have a patient who got any infection, maybe a bacteria, virus, fungal, parasite, or who got some environmental exposures of chemical or anything over a longer time. This infection does not mean that, okay, got typhoid and these things are activating. No, subclinical infection which are ongoing, right? Or patient got some cancer or something. So these are kind of a trigger. But many of this, see, we are exposed to bacteria, virus, and everything, them every day, and our immunity fights it. Things are fine. But sometimes if you have a genetic background, like this kind of HLA background, some polymorphism in this gene, or some susceptibility to this adult onset disease, then when this trigger come, our macrophage will behave little differently. What will happen is whenever the trigger comes, so something bad is happening, body will sense it. How does the body sense it? The body sense it through some receptor, which is called PRR. That's a pattern recognition receptor on the cell surface or inside the cytoplasm. When body is sensing through the PRR, what it is sensing? It is sensing PAMP, that is pathogen associated molecular protein, or the damage associated molecular protein. So it's a lock and key. The PAMP and the DAMP are the kind of key which are setting on the lock, which is PRR. Now, if in this population or this genetically susceptible person, if this kind of keys are coming, it will activate the lock, and lock will ultimately open the door towards something called NLRP3. So when that door is open, macrophage will secrete particular cytokine like IL-1 beta, IL-18, which will activate innate and adaptive cell. Innate cell will be macrophage, dendritic cell, and to the certain extent, your neutrophils also, and your adaptive cell of Th1 and Th17 arm. Now, whenever all these things are getting activated, they all will secrete cytokine. It's called cytokine burst, right? Cytokine storm, and it will release them everything. IL-6, IL-17, IL-1, TNF, and all. And sometime what happens when all these things are going bad, we have something called a regulatory mechanism. Let's control that. So RAMP will come in picture. That is your regulation associated molecular protein, and it will bring down all this thing by all this cytokine and all, and inflammation will resolve. Now come to this picture and come back there, right? You got a person with some susceptibility, with some trigger, and he had this cytokine burst. And during this burst, he had fever because there was IL-1, IL-6, TNF, which are pyrogenic cytokine, right? So he had fever, he had high CRP because IL-6 was high. So that will stimulate that part. So he had some decreased weight and all because TNF was there in the picture. So all these things were going on, but his regulatory mechanisms were great. It came up and controlled everything and things were fine. So everything got solved, and then the regulatory mechanism was so good, it kept everything in check. It never happened. Now, the second scenario, a person gets all this thing, the regulatory mechanism kept it in check, or you made a diagnosis of AOSD and you treated it well, patient was doing well, and you stopped the treatment because everything was fine for 6 months to 1 year, and then nothing was happening. Again, a trigger came in a genetically susceptible individual. Again, it happened. Again, the resolution happened, and things were going on. Now, the third case, okay, something started, but this resolution molecules were not able to take care it properly. So the disease is continuing throughout, right? So without remembering them, everything what is happening here, you are actually understanding the concept. It's all about equilibrium in immunity, right? That's how patient disease course changes. And it is so beautiful to know all this thing, that what is happening to our patient, right? And why we are treating. When a patient tells me that this, I will give you one example that I had one case during COVID, that I was seeing a guy who was around 31-year-old male. He was a driver in government. So when he was a driver in government, he actually got this vaccine little earlier compared to the normal population, right? So after he took vaccine, after 2 to 3 months of that, he developed this episode, okay, which had fever, rash, polyarthritis, and he was quite sick with high ESR, high CRP, thrombocytosis, leukocytosis with neutrophil. Obviously, received all kind of antibiotic, nothing helped, right? So this point, we gave NSAIDs some response. He had a high ferritin. We made a diagnosis that, okay, this patient is having Still's disease. Why we made a Still's disease? Because on taking history, he told at the age of 9 years, he had similar kind of thing, but after some time, it got resolved completely. At this point, we made a diagnosis, we gave steroid, it was working, but not adequately. So we tried or we planned therapy with tocilizumab. We gave initially methotrexate cyclosporin, but no great response. It required dexamethasone daily 8 mg or more. That's quite a high dose. Believe me, that's quite a high dose. So it was not working. So I told that, okay, you have to take tocilizumab. Obviously, he told that we'll need to arrange some money and then we will come back. Now, when he was arranging money, this resolution worked. And I was like, what happened? And he told us, sir, now nothing is there, right? So that's what happens. But we were able to convince that it's something, the nature which is working, and we did not require tocilizumab, and then things are fine. Now he is here. I don't know when this is going to come. He's actually off treatment of them, everything, right? But if a new trigger comes, he knows to whom he should come to, right? That's our job to determine. So this can happen in your clinic also, in your practice also, and we have to deal with that very smartly, that what we are doing with that, right? So this is something to understand this. Okay. What else should we consider in a differential diagnosis when we find? So obviously it's like PU, your infectious disease, your malignant disorder, and your other systemic disorder, including autoinflammatory syndrome. This is also a part of autoinflammatory syndrome to tell it should be considered. And then there are certain things like post-streptococcal arthritis, reactive arthritis, Schnitzer syndrome. There is a lot of thing there. It's all available, right, to read. But it tells us that AOSD does not come on day one as a diagnosis all the time. We mostly visit patient and day 4, 5, and this all things mostly have been taken care. Malignancy, obviously, we have to see properly, and this kind of cases. Now, are we even rheumatologists if we do not talk about the criteria? There are 3 criteria for making or classification of your adult onset still disease. The first criteria is the Yamaguchi criteria. Second is your Fautrell criteria. Third, I have not written here, it's called Kush criteria, CUSH. Okay. Now, I really don't want you to remember them any criteria, because now you identify AOSD to the certain extent. So now try to correlate here. You remember it when you are going for MCQ. And now let me tell you a secret. After becoming rheumatologist, we never use criteria. We don't need it. You identify disease by its nature, not by criteria. Why then this criteria? Two purpose. To ask in MCQ. Second, if someone tells, I want to do research on AOSD, you have to take all the patient who satisfy this criteria. It is for research. It is for making a good cohort. It is to do thesis. It is not every day in practice. So if a patient has fever for more than 1 week with arthralgia, with typical skin rash, this typical skin rash does not come here all the time, with leukocytosis, with neutrophil dominance, which are major criteria, minor criteria being pharyngitis or sore throat, lymphadenopathy or splenomegaly, transaminitis, negative ANA, negative RF. See, the criteria says that RF and ANA should be negative, does not mean you order for them everyone. You do not work up like criteria, you work up clinically. How many patient of rheumatoid arthritis have you seen with PUO lasting like this? No, you are not seen. How many of patient of RA will have transaminitis without taking methotrexate, leflunomide, or any other drug? You won't have it. Respect your case to case, what how the disease is. That's why we should read more and more. What happens to LFT in RA? Okay, it is normal. We have to be confident about that. It is normal. If it is not normal, we have to think beyond RA. We have to think like drugs or something else, right? So we have to keep thinking like that. Exclude few diseases, specifically sepsis, malignancy, and autoinflammatory disorder, and vasculitis. And if everything is done, if you have a 5 criteria, including 2 major and no exclusion criteria, your diagnosis of AOST is done according to Yamaguchi. Okay, now see, now compare this criteria to your criteria of acute rheumatic fever. You have fever, you have arthritis, you have leukocytosis, you have a skin rash, you have pharyngitis. Damn, everything is there, right? So it can really confuse it. What is little odd here? The odd here is transaminitis, which is not there with your acute rheumatic fever. So when you have this comparison, your mind should work as a patient that, okay, in this patient he had transaminitis. I made a diagnosis of ARF, responded beautifully to naproxen, and patient is now on penicillin. We did something wrong there, right? Try not to do that. I'm not telling we can stop it completely, but try to be more mindful when you are seeing a patient. Don't make diagnosis in 1 second. I see few doctors who make diagnosis like this. Okay, this is lupus, this is this. No, don't do that. Don't be superhero. See everything and then make a diagnosis that will be more beneficial to your patient. Okay, that makes a difference, right? So this is what comes. There is another criteria in that there is a fever, arthralgia, erythema, pharyngitis. Then you have a neutrophilic leukocytosis, glycosylate ferritin. Anyhow, we do not have that. Typical rash and leukocytosis, and you need a 4 criteria or the 3 major and the 2 minor criteria to make a diagnosis. See, all these things are sadly asked in our exam in MCQ, but actually you do not need it. Sometimes the benefit is when you remember the criteria, you start suspecting, okay, you have fever, leukocytosis, high CRP, high ESR, and this thing, suspect AOST, right? That's how it done. Now, last 2 slides we are discussing. What is your plan beyond hope? Okay, because these are kind of tough cases. What we do? See, it is only tough when we do not know. For me also, it was for everyone. I think every medicine resident has experienced AOST like this only. That it was too tough, but someone came, senior, who has seen enough AOST and told, okay, it can be OST. Please send that ferritin and give naproxen or rituximab. And when he gives naproxen or rituximab, damn, everything is done. Patient is very happy. And he does not trust you even as a resident care. That senior doctor was so good that he made a diagnosis, and you were playing with me for 3 days by sending culture, doing CSF, ordering CT, right? It happens. But the good part, what you did is you did culture, you ordered CT, you did CSF, so you ruled out them everything. That's why that senior consultant made the diagnosis. So do not let them take any credit. You did that. But we were just not knowing that it is AOST, right? So always give NSAIDs on exploratory phase. Exploratory phase means when you are trying to determine. So tomorrow you go to ward and you have a patient of PUO who has high count, little high ferritin, high CRP. Do not make diagnosis of AOST. Be sure, damn. Okay, because this presentation can mimic so many things. And it happens to everyone that when we read something or when we hear something, next day we start suspecting that. Okay, it does not happen like that. Be very mindful. So when you see and when you have the NSAIDs, if patient has a complete response with NSAIDs, we are just going to monitor them. Sometime it will settle forever. But if patient has not complete response to NSAIDs, steroids are going to be my choice. And whenever I give steroid, I am very careful that, okay, I'm not dealing with infection. I'm careful, but I cannot be 100% sure. We are human, right? But we do not make obvious mistake. It is not human makes mistake. We never make obvious mistake as a physician. We should not, right? So when you're planning a corticosteroid, that will be the therapy. And we mostly add methotrexate in most of the case. If methotrexate is not working that great, if patient does not have good response to corticosteroid, we are going to go for IL-6 inhibition. See, we do not have IL-1 inhibitor available in India very freely, right? That's anakinra. So we do not have anakinra or canakinumab available. We have IL-6 inhibitor tocilizumab available. And now I can say you have used tocilizumab as equal as I have used, because in COVID we equalize that part, right? Then the IL-18 inhibitor, they are in a way trial, they are showing very good result, but again, it is not available here. Okay, we use cyclosporin also, sometime it helps, but cyclosporin, methotrexate are slow drugs. Tocilizumab is like magic here if your diagnosis is correct. If your AOST does not respond to tocilizumab, it is unlikely to be AOST, right? So we don't want to prove it like that, man. Come on, right? So this is what it is going to come here. And if again they respond, then it is fine. Sometime if arthritis part is too much, then you can use TNF inhibitor, that is radalimumab, infliximab, or golimumab, which is available in India, or sometime even aternacept, or the cyclosporin can be useful, right? So this is our overall plan. We should be knowing this is how we deal it. Because once you make a diagnosis, and believe me, AOST case is seen more with medicine than rheumatology. Okay, you people see more, so you should know what we are going to do, or you should know whom you are going to ask, right? What are the therapy available beyond this? This is more for your MCQ and everything. You have a IL-1 receptor antagonist like anakinra, IL-1 beta antibody canakinumab. Then you have rilonacept, infliximab. This all we discuss. IL-18 antibody, that is a tediking alpha. Then your rituximab and all. This all can be tried. But believe me, this is one which is going to work. IL-6 receptor antagonist. We actually try to divide this patient. What is the main problem? Fever, then tocilizumab. Arthritis, then TNF blocker. That's how we decide biological in India that what we are going to do. So I think with this, I will complete the discussion. And you have any doubt, you feel free to ask. We'll discuss that. You can message, or if there are no doubts, I will feel it is good class. Thank you. Fine. So I think I should stop the meeting. Thank you. Okay, fine. What is the prevalence like? How common it is? Okay. So it is actually common, but the people diagnosing it are little rare. Okay. It is not that common, I will say. If you're working in a hospital which is a decent load, if you consider all of your PUO cases, out of 30-40 cases, there will be one or two cases. Why I'm telling like this? Because we do not have exact data to tell what is the prevalence, right? So it is actually there, it exists. There are two important things what you have to consider. That a very simple history taking, that when fever is that, patient is sick, but when fever is gone, patient is playing. This is likely to be OST. Your infective endocarditis patient, do not do that. Your osteomyelitis patient, do not do that. Your septic arthritis patient, do not do that. They are continuously sick. Your pneumonia patient is continuously sick. It does not have like this two extreme of diseases, right? So when you have that kind of pattern, your malaria patient still can do that, quotidian fever and all. That when they're having fever, they're too sick, otherwise they are fine. So this fever pattern, when you have ruled out the infection, when your antibiotics are not working, you have high CRPS or high total count, order that ferritin. If that comes too high, give NSAIDs and see what is happening. If they respond beautifully to NSAIDs, see, malaria won't respond beautifully to NSAIDs, come on, right? So if it's responding beautifully to NSAIDs, you are probably dealing with this. And then you look at that Yamaguchi to just see that what is happening. Patient is having this criteria, other things I have ruled out, and then you have made the diagnosis and plan the treatment, right? Fine, fine. Great. Yeah, what's the NSAIDs of choice? I will say using NSAID is an art. Okay. If patient has too much gastric trouble, my NSAID of choice is etorecoxib. If patient does not have that much problem, I want to use it for a shorter time, ibuprofen is my drug of choice. If patient has some cardiac issue, so-called naproxen is the drug of choice. It's a cardio safe, right? So that's how we determine. Ibuprofen is a shorter acting drug. So we'll give relief for some time, but after that, we do not know. Etorecoxib is little longer acting drug. It will give sustained relief if it's really going to work, and it won't give you much gastric trouble. Okay, so you have to choose accordingly what. every NSAID has equal renal problem, equal cardiac problem. The gastric problem differs little. Cardiac, for exceptions, NSAIDs can, naproxen can come as per the data in MCQ, but as such they are same. So it is up to you what is available in your hospital and what you are choosing, and they are not that expensive. So you are definitely use it. Fine. Sure. So we will conclude the meeting. Thanks a lot.